So continuing our discussions with respect to anatomy, having particular movements as our central feature in our semantic network. So we're attempting to associate anatomical structures with the movements that they are related to. Now, you're going to have a lot of overlap in that there are going to be many structures that are related to, or some structures that are related to many different movements. So there's a lot of overlap. That is on purpose, at least with the aims of this project. We are really trying to be redundant so that there is repetition and that you are having the same things pop up again and again as particular details that relate to the central meaning of motion and then relate to different motions. So what you're going to have is you're going to have a semantic network that has a bunch of different details that relate to specific motions, and then those details relate to other motions. So now all of a sudden you have different ways to relate both specific details or specific structures to multiple movements. Therefore, you'll be able to call on these pieces of information in multiple ways, depending on what you're doing, what you're considering, what you're finding. So our main objectives here are a specific discussion of what side bending and rotation are, because this one is about cervical side bending and rotation. So we are going to discuss planes and axes. Now we've done this with respect to cervical flexion and cervical extension, and those are both in the sagittal plane. But here we have to discuss both the coronal or the frontal plane and the horizontal or transverse plane and their associated axes. We are going to have a specific discussion of the muscles that side bend and rotate the neck. Now, this is actually really simple because we've already talked about all these muscles before, but in this particular case, we're just going to split them up so that you understand what's going on with respect to how this works, because there's really one quirk, and that quirk is the SCM, so that's a little bit of foreshadowing. But otherwise, it's all pretty darn straightforward, and we've already talked about these. We're going to have, again, a specific discussion of head versus neck side bending and rotation. So we've already had this general discussion before with respect to head flexion and versus cervical flexion and head extension versus cervical extension. So there's going to be a lot of similarities there. So again, redundancy on purpose, redundancy for good reason. We're going to have a general discussion of the neurovascular supply. Again, this is really easy because these are all the same neurovascular pathways that we've talked about already with flexion and extension of the head and neck. We're going to have a general discussion of the areas to assess and treat should cervical side bending and or rotation issues be suspected or reported. Again, very redundant because this has already been done for cervical flexion and cervical extension. So we're talking here again about, although the Q is wrong or the title is wrong, it says what is flexion. It should say what is side bending and rotation. So small mistake there, but no big deal because I can tell you that we're talking about side bending and rotation. So your planes, your cardinal planes, cut the body into 50% halves. So the sagittal plane is 50% left to right, the horizontal plane or the transverse plane is 50% top to bottom, and the frontal plane or the coronal plane is 50% back to front. Again, axes are perpendicular to the planes. So with respect to the horizontal plane, you're going to have the plane being here. So you have the perpendicular axis, and the perpendicular axis in this case would be termed often a vertical axis. You could, in some circumstances here, people call it a sagittal axis, but it's very unlikely that they would call it that. Usually it would be horizontal or transverse plane on a vertical axis. The frontal plane, or the coronal plane, would be an AP axis. So it's this plane. So maybe if I do it this way, it's this plane and the axis is here. So it's from front to back or back to front. You can call it an AP or APA axis. So anterior to posterior or posterior to anterior. It depends on where you want to put your attention, but it's basically an axis that goes from front to back. So those are your planes and your axes. Now, the horizontal plane would be rotation, or the transverse plane is rotation on a vertical axis. So because the axis is here, the plane is here and the axis is here, you get rotation this way. With the frontal plane, the plane is here or here, cutting me back to front. So the motion is going to be side bending. So it's on that AP or PA axis, right? So it's side bending. So horizontal plane or transverse plane is rotation, and the frontal or coronal plane is side bending. So that is where they occur and ways to describe them with respect to planes and axes. Which muscles are we talking about here? So if we're looking on the back side, we're talking about the trapezius, the levator scap. We're talking about semispinalis, capitis and cervicis, some splenius, capitis and cervicis, longissimus, capitis and cervicis. Specifically with respect to the head, you're going to do longissimus, splenius, and semispinalis. capitis, rectus capitis major and minor, obliquus capitis superior and inferior, right? You're going to be talking about those things. Row multifidus, interspinalis, well, no interspinalis if I remember properly in the cervical column, but then rotatories, you're going to have those all involved. If we're looking on the front side and the side or the lateral side, you're talking mostly about anterior, middle and posterior scalenes. You're also talking about longus capitis for the head, longus coli for the neck. You're speaking of the SCM. You're speaking of rectus capitis anterior and lateralis. So you've got all of these muscles being involved in side bending and rotation. Now, the way that this generally works is that whichever side you're talking about, so if it's the right side of any of these muscles, it's going to side bend and rotate to that side, right? So the longissimus capitis, if it were to contract only on one side, you would get head side bending to that side of the head and rotation to that side of the head. That is how that would work. Whereas if you're talking about, say, the scalene muscles on the left side, you would get side bending to the left and rotation to the left if those muscles are contracting. Now, the one trick, and we'll talk about this again a little bit later, is the SCM. The SCM is known to flex the neck, extend the head bilaterally, but what it does is unilaterally, it's going to side bend to that side, but rotate to the other side. So it side bends to the right, but rotates to the left. That's the only quirk. Everything else side bends to its own side and rotates to its own side. The SCM is the one quirk in that it side bends to its side and rotates to the other side. So we've touched on the concept of the head head side bending and rotation versus neck side bending and rotation. So if it's going to be the head, the neck is going to be relatively still and the head is going to side bend and rotate. And the way to differentiate is that the neck isn't going to do very much there. So the movement is generally going to be quite small. The head is going to move, right? Side bend, rotate, versus the neck and head side bending and rotating. Now you can rotate the head to one side, but you're going to have a hard time rotating the neck to the other side. It generally works as a unit, especially because of how the muscles move and express themselves. So another way of saying that is you can have head and head rotation and head side bending, and then you're going to continue on with the motion. You're going to get head and neck side bending generally in a united way. You can, again, side bend first and rotate after, right? You can rotate first and side bend after, so you can get it to go away, and that's more or less the function of this SCM or sternocleidomastoid. However, other muscles may be able to get involved because you change one plane first and then you change the other plane, right, as you go. So in this case, if it's the head, you're talking about all the capitis muscles, so the rectus capitis anterior lateralis, posterior major, posterior minor, your obliquus capitis superior inferior, longus capitis, semispinalis capitis, splenius capitis, longissimus. Oh, no, longus capitis is anterior. Sorry, almost thought I made a mistake there because the longus capitis and longissimus capitis messed me up. Longus capitis is on the front, longissimus capitis is on the back. And then you're going to have the SCM and trapezius also contributing to head side bending and head rotation. As far as side bending and rotation of the neck, it's a moving neck on a relatively still torso. So the torso is going to be still and the neck will twist, or the neck will bend side to side. Now, in this case, we're talking about generally all the cervicis muscles, so semispinalis cervicis, splenius cervicis, longissimus cervicis, and longus coli not being a cervicis, but there's a longus capitis, so then you flip over to longus coli. The scalenes, anterior, middle, and posterior, levator scapula, trapezius, and SCM for movement of the neck on a relatively still torso. But the SCM, as we already noted, is the tricky one because it does side bend to the same side. So the left SCM will side bend to the left, but it will rotate to the right. So you can get that mixed motion. So it is the one tricky one. Everything else side bends and rotates to its own side. Yeah, so it's already there. I forgot to look at the screen, but it's already there. Everything else aside from the SCM side bends and rotates to the same side. Now the nerves, we're talking about the dorsal primary rami. So essentially for all your paravertebral muscles or your prevertebral muscles, well, not prevertebral, but your vertebral muscles. So your semispinalis, splenius, and longissimus, right? So those are going to, whether it's cervicis or capitis, is dorsal primary rami going back out of the mixed spinal nerve. You're going to have segmental branches, and here's where we're talking about longus, capitis, and coli, and that's on the anterior side. So the anterior rami, these are not things that are going to a plexus, either the cervical or brachial plexus. They're just going direct, more or less, to muscles. So you have that to longus, capitis, and coli, and scalenes. Now, you also are going to have the dorsal scapular nerve with respect specifically to the levator scapula, and the accessory nerve, or cranial nerve 11, going to the trapezius and the SCM. So for complete function of the accessory nerve, it's basically shoulder shrug for the trapezius. So it's going to pull that up, and then it's going to be head extension, right? Sorry, rather neck extension and head extension, right? So it's kind of like a slouch like that. So if somebody asks you, what does the accessory nerve do? And you go, I don't know, then you more or less have all the actions. That is what it does because it's a motor nerve. As far as the vascular supply, we're primarily speaking of branches off of the brachiocephalic trunk. So we're going to talk about the brachiocephalic trunk because that's where it splits life to right to left off of the ascending aorta, or the aortic arch rather. And you're going to have from that the common carotid, and you're going to have the subclavian on both sides. Now, off of the common carotid, we are considering mostly branches off of the external carotid, providing arterial supply to muscles of the neck that are going to side bend and rotate. We are considering in some sources branches off of the vertebral artery, right, which is going to be off of the subclavian, but the internal carotid may give us a tiny bit, or the internal carotid can be considered primarily because it's going to supply the brain and supply the nerves within the brain. So you can have a discussion there, but it's mostly external carotid, the vertebral artery to some degree, because some sources will say that some of the deep neck muscles on the anterior side will get some supply from the vertebral artery or branches from there. We're considering the costal cervical trunk and the thyrocervical trunk. The thyrocervical trunk, specifically the transverse cervical artery. Then we're going to consider the internal jugular vein and just generally your subclavian. So anything that goes to the subclavian veins, you're considering. The areas that you'll identify mechanical changes that might impact both of these circulatory pathways: the neck generally, the first two ribs, the scalenes, the SCM. You're not necessarily going to be able to pull the scalenes apart from anything, but the SCM you can, and then how the neck is moving will allow you to interface with the upper two ribs, the clavicle, and all the muscles that are going to side bend and rotate. As far as lymphatic pathways, you're talking about along the SCM, the angle of the jaw, but really your terminal drainage points are going to be into the subclavian veins at the right lymphatic duct and the thoracic duct for everything else. So the right side of the head, neck, and arm, and then the left is the right lymphatic duct. The left side of the head, neck, and left arm, as well as the entire body, are the thoracic duct. Right, so you're considering the relationship between the SCM, the clavicle, the first rib, the anterior scalenes for all of these things. And the way that you're going to really identify that is not picking that apart very specifically. It's going to be in the gross motion of the neck with respect to side bending and rotation, because if it's not side bending and rotating evenly, and there is no obvious major difference as far as the bones are concerned, because you're not going to see a lot of scoliosis in the neck. Your bones are probably pretty even. So if there's a mismatch left to right with rotation or with side bending, then you're considering that there could be mechanical pressure from that alteration in movement on any of these structures. Now, your general considerations with anything, whether it's flexion, whether it's extension, whether it is side bending or rotation, as far as when somebody comes in, what are your red flags with the neck or anything clavicle up? So changes in memory or speech. So if you've seen the patient before and it's obvious that they're having problems with memory that they wouldn't have had before, then you want to be very concerned. You want to refer out at that point. Any changes in speech, so even if it is somebody you've never met before and their speech changes within the appointment, or their speech seems notably off with respect to rhythm or with respect to clarity, you want to ask a few more questions. So those are signs of possible issues with. You don't want to absolutely jump to a particular conclusion. You just want to know that these are red flags that you shouldn't investigate any further. You should send out, but you're considering things such as possible stroke, so recent or current. You could be possibly thinking about neoplasms anywhere along the neck or in the brain, so benign or malignant. So if you're able to note any changes because you know the individual with respect to memory or speech, you're very concerned. If it seems off, even if it's your first meeting, you want to be very concerned. A recent reported trauma directly to the head or directly to the neck, you would rather refer out prior to treatment for safety concerns, because there could be something there that neither you nor the patient is aware of that you will not detect with your external manual methods. Recent rapid changes in vision. So major changes in vision, you want to be very concerned because you don't know if that is neurological or if it's vascular. Anything that is a known ocular pathology or an ophthalmological pathology with a requirement to avoid increase in pressure, you don't want to work in the head or the neck. But the things that are going to really concern you if they walk in that you want to send out immediately is recent reported direct trauma to the head or to the neck. You want to make sure that they're checked over, and changes in memory or speech, right? Whether recent or current. Those are very concerning. You want to send those out. As far as areas for assessment and treatment with respect to issues suspected of or reported for side bending and rotation issues within the cervical region, be it the head on the neck or the neck on the body, then you're going to be considering the upper ribs, so ribs 1 and 2 with respect to the scalenes, the clavicle itself, so the SCM, and to some degree the trapezius. The SCM, all of those things for vascular considerations, be it the arterial side or the venous side. The cervical vertebrae, generally speaking, so how the neck moves one side to the other, very, very broadly speaking. And you're considering motion issues there, as well as possible neurological considerations. You're going to have a hard time picking those apart, but there are some minor ways where you can get a sign where if you're concerned about a neurological issue on one side, such as a palsy, you may pick it up with active testing, whereas if it's just general motion, then, and maybe on the sensory side, you may find that through passive motion. You're obviously going to check the head on the neck and then the scapula because you're concerned or curious about the SCM, rather the levator scap and the trapezius. So the movement of the scapula can relate to the neck. So if the neck isn't resolving, if you've assessed the neck and treated the neck appropriate to your findings and it's not resolving, then the trapezius, the motion of the trapezius, can have a large impact on that because of a very large muscle in the scapula, or sorry, the trapezius, and a smaller muscle in the form of the levator scapula. So you're going to assess and treat all these things with concern for the local region of the neck or anything above the clavicle. So these are all of your concerns. As I noted, with respect to anything above the clavicles, the areas that you're going to assess and treat are all going to be the same, regardless of the underlying concern, right? The underlying sign of the patient or the underlying symptom of the patient, what they can identify being the symptom, what anybody can identify, including them and yourself, being the sign. You're going to assess and treat the same structures. So what you find not moving is what you treat, regardless of what is reported, right? We work on sign, we don't work on symptom.